the ECG is the number one tool in the diagnosis of heart problems, but like any diagnostic tool, they're only as useful as our confidence in interpreting the information they offer. If you have that set of ECGs that we sent you with you, pull them out and have a look at them while Dr. David Playford from Heart West talks us through what each of these ECGs is telling us and what action, if any, should be taken in response to them. Now, hopefully you'll have recognized ECG number 1 as a normal ECG, so we started by asking David about ECG number 2.
David, could you have a look at ECG number 2 and tell us what's going on there?
This is a patient who presented with retrosternal chest pain of 2 hours duration that sounded ischemic, and on the ECG you can see that that in the first of all, the rhythm is sinus rhythm. The rate is about 60 beats per minute. And if you look in the inferior leads, which is leads 2, 3 and AVF, you can see that there is ST segment elevation. From the beginning of the ST segment to the beginning of the T wave, there is elevation of that entire segment, which is consistent with an inferior myocardial infarction in evolution. Taken in context of the history, so it's very important to join the ECG changes with the history to make sure that it's happening as we speak.
Are there any ischemic changes that are acute that are much more subtle than that fairly obvious inferior infarct?
Sure. There are some infarcts that present in a slightly more atypical sort of way. The first thing always is on the history. If it sounds ischemic, then always be concerned that it is an infarct or at least an ischemic pattern that's happening. This is somebody with an evolving true posterior myocardial infarction. Nowadays we try not to use the term true posterior. In fact, it's really a basal inferior. In fact, it's one of the forms of inferior myocardial infarction. But you can see here on leads V1, V2, V3, and across the other 3 anterior leads, V4, V5, V6, you've got ST segment depression, but an upright T wave, particularly obvious in leads V2 and V3. And you also can see that the R wave is bigger than you'd expect it to be in V1 and V2, particularly obvious in V2. Normally the R wave is smaller and gets bigger as we go across the rest of the anterior leads. In leads 2, 3 and AVF, which are the inferior leads, there is ST depression, but there's no elevation there. So these are the changes that we see in somebody with an infarct that is at the back of the heart, and so the ST segment changes are the opposite of what you'd see if they're in the front of the heart.
Moving on to ECG number 4, David, that looks like a quite abnormal ECG. What sort of things would you expect in the patient, and when would you see changes like this?
Often a patient like this one is surprisingly symptom-free. If you have something that maybe is a bit breathless with exertion, or perhaps it has a history of aortic stenosis, or somebody with a history of long-standing hypertension. This is an ECG of left ventricular hypertrophy. There are a number of different criteria that have been developed. One that I use is using V1 and V5. If you add together the S wave in V1 and the R wave in V5, if it's more than 35 millimetres, then that's suggestive of left ventricular hypertrophy. There are other criteria, but that one is reasonably reliable. Now, the other thing that goes with this is changes that look like ischemia. So in V4, V5 and V6, you can see there is ST segment depression and there is T wave inversion in those leads, and that is consistent with ischemia. Some call it a strain pattern, but it's not really strain. It is true ischemia. It's ischemia due to hypertrophy, not an ischemia due to coronary artery disease necessarily. So it's one of the changes that goes with left ventricular hypertrophy.
So David, slide number 5 shows an ECG that is quite often difficult for country GPs to interpret, particularly if it's the very first ECG the patient's ever had on a standard insurance medical or such like. And we never know whether or not these kinds of changes are indicative of disease. So could you perhaps go through how we identify the changes and whether or not we need to attach any significance to them?
Absolutely. This is quite a common finding. In fact, an isolated finding of a left anterior hemiblock, which is what this ECG shows, doesn't necessarily indicate any disease that requires further investigation. If there is no history of any cardiac disease, left anterior hemiblock generally doesn't require any form of intervention. Usually it won't affect their insurance status, and generally what I would do is just note it, check to make sure there's no symptoms in the patient, and then really leave it at that. As far as interpreting it, I'll just quickly go through it. It's isolated left axis deviation, so you can see that leads 2, 3 and AVF have a predominantly downward deflection, whereas lead 1 has a predominantly upward deflection, and that is the sort of thing that's how you would diagnose a left axis deviation, but there is nothing else abnormal about the ECG. It otherwise looks fine.
Slide number 6 shows again a fairly common finding, and the patients do often complain of an occasional thump in their chest. Is this something we should be concerned about?
Ventricular ectopics are incredibly common. Almost everybody has at least 1 or 2 ventricular ectopics. Some people feel them, some people don't. It's always worth doing an ECG if somebody complains of palpitations or a sensation of a thump in their chest. If you see 1 ventricular ectopic, it really doesn't mean anything. It's a normal variant. It doesn't mean anything. Ventricular trigeminy itself, again, apart from it meaning there's a lot of ectopics happening, doesn't really mean anything particularly. So you can have ventricular trigeminy, have no symptoms, and have a good prognosis.
Okay, so it's not going to trip into a run of VT necessarily?
Not necessarily. Most of the time it doesn't.
So could you have a look at slide number 7?
Most people, when they look at this, will immediately think of this as ventricular tachycardia, and indeed it is. Like I was saying before with the other abnormalities, you look at the patient. If the patient is compromised and they have a broad complex tachycardia like this, you cardiovert them, irrespective of whether you really think it's a VT or not. And final thing to say is if somebody's over the age of 60 and they've got a rhythm like this, it's always VT.
What about the patients who have little runs of VT and then revert to sinus rhythm?
If the runs are short, 4 beats, maybe 5 beats, that's actually relatively common, and it is associated with an increased risk if there's coronary artery disease associated with it. But surprisingly enough, some people have short runs of VT that we can't find any structural abnormality in their heart, and there's really no strong association with the increased risk. So yes, it's worth looking if somebody has a run of VT, but you don't necessarily always find something.
That, I think, is what we're seeing on slide number 8. And this would be when a GP would refer the patient on to a cardiology service to get an echo and a Holter monitor.
Yes, I'd recommend that in this particular patient you should look a little bit further. First of all, there's 2 runs of VT. You can see there's the first run on the left-hand side of the ECG, and a second one that's a bit longer, lasting 9 beats on the right-hand side of the ECG. And this does generally indicate some abnormality with the left ventricle, either a cardiomyopathy, a previous myocardial infarction, coronary artery disease, that sort of thing. So yeah, it is worth looking into a bit further.
Moving on to slide number 9, my suspicion is that this is a first-degree heart block. When does a GP worry about a patient whose ECG comes up looking like that?
Okay, so a first-degree AV block is defined as a PR interval greater than 0.2, which is 1 big square. If it's just over 0.2 seconds or 200 milliseconds, then it really doesn't mean anything in particular. If the PR interval is very long, so 0.3 like this or longer, then they often do progress to higher degree blocks such as second degree or complete heart block in the future. And again, take a careful history and see if there's any evidence of pre-syncope or syncope, or if there's ever been an episode where they've just collapsed without any obvious cause.
Okay, so this is something where the patient might require pacing, but only if they've got symptoms.
They won't require pacing just for the presence of a first degree, but if it goes into higher degree block, which is something that would be indicated by the presence of symptoms, then yes, it's possible.
A 10th ECG is something beloved of all cardiology students.
This is an ECG of Wolff-Parkinson-White syndrome. There are a number of different accessory pathways that can occur around the heart. Normally there is only a single channel that allows the electrical conduction to go from the atria through to the ventricles, and that's through the AV junction. If there's an accessory pathway, then if the transmission of electrical signal goes through there predominantly rather than through the normal channel, then you'll get what's called a delta wave. And if you look at the PR interval, probably the best place to look would be, say, lead 2, or you can see it in the anterior lead, such as lead V4. You can see that there's a P wave immediately followed by an upstroke, which is called a delta wave, and then the QRS complex. And that delta wave, or that upstroke, that early upstroke straight after the P wave, is caused by electrical activation through the accessory pathway and causes activation of the ventricle a little bit earlier than you would normally see. And so anybody who has Wolff-Parkinson-White syndrome should be seen by a cardiologist with a view to ablation of the accessory pathway.
And finally, David, the very last ECG in the pile. That looks like a very abnormal ECG to me, but I'm not too sure what's going on.
Sure. The reason I wanted to put this one in is because it's not that uncommon, particularly in emergency department setting, for someone, often elderly, to present with feeling unwell, feeling breathless, and presenting with palpitations. But the ECG, particularly on the automated reports, will often come out just saying sinus tachycardia. But if somebody is older and they have a resting heart rate above 100, it's usually not normal. It's usually due to an arrhythmia of some sort. So in this particular one, this is what's called a junctional or RP tachycardia. What you can see is the QRS complexes themselves are normal, they're narrow, there's no evidence of any obvious ST or T wave abnormalities, but if you look closely you can't see the P waves in the normal place. There's no P wave before each QRS complex. What you can see instead is that there's a QRS complex, and then straight after the QRS complex there are P waves, and that happens with every single QRS complex. So these are called retrograde P waves, and in this particular case what's happening is that the activation is happening at the site of the AV junction, and then the electrical signal is fanning out in both directions, forward as a QRS complex and backwards as a P waves. Yeah, and so an older person who presents with resting heart rate above 100, be concerned about the possibility of some form of atrial tachycardia or junctional tachycardia.